Okay, so hi everyone and welcome to BrainMap. This seminar series is co-sponsored by the P41 funded Center for Mesoscale Mapping housed in the Martinos Center. It's my great pleasure to introduce our speaker today, Dr. Florian Knoll. Dr. Knoll received his MSc and PhD degrees in electrical engineering in 2006 and 2011 respectively, both from Graz University of Technology in Austria. He is currently an assistant professor in the Center for Biomedical Imaging at NYU School of Medicine, and his research interests include iterative image reconstruction, parallel MR imaging, compressed sensing, and machine learning. I would just like to remind the audience to please address any question you have using the Q&A box or just raise your hand. Dr. Knoll, thank you so much for coming here today. The virtual stage is all yours.
Yeah, thanks very much for the kind introduction, and thanks for the virtual invitation. I hope I could be up with you in Boston. Maybe sometimes in the future we can make it happen, but I hope at least virtually, yeah, we can have some discussion and some interaction. And what I'm gonna present to you today is a bit of a almost historic overview about what we, like in my group, have been doing in image reconstruction using machine learning, starting from when we started this project almost 6 years ago to what we are doing now. And I'm gonna balance it by both showing you some of the things that we got that excited us, some of the results that motivated us to pursuing it, and also balance this with showing you some of the things that we found challenges, things that I believe are issues. If we really want to continue using this technology clinically, what are the things that we need to be aware of? What could go wrong? How can things go wrong? So I'm just going to share all of this with you, and then anytime you have a question about anything, just let me know, and then we can discuss, and either during the talk or in the end. And I want to point out that all of this is work of a fairly large group, both my group at NYU and external collaboration partners. This whole thing was started as a collaborative project with my former collaborators and friends at Graz University of Technology. Then we added this collaboration with Facebook AI research, and there's also a component with Siemens, particularly for low-field scanning. All right, so to get us started and just to get everybody on the same page, I mean, you all know this, and but just to make sure that I introduce my notation, we acquire our MR data in Fourier space, and so what I have here is the classic MR signal equation. We have an image U, we have these exponential encoding functions, coil sensitivities, and this maps us to our MR raw data. And if we write all of this in matrix form, then the image reconstruction problem just becomes this linear inverse problem. And if we have a fully sampled set of case-based data available, then just an inverse Fourier transform gives us our target image, and we are done. And I'm sure this is also something that all of you are very aware of, is that there are lots of challenges in MR that are connected to the long scan times that we have. So we have issues with patient comfort, patient compliance. It makes MR a very costly modality. We have issues with motion artifacts with long scans, if we have uncooperative patients, if we have young kids, breathing artifacts. And there are also issues where we simply cannot afford to take a long time scanning. Every time we want to measure dynamic processes, for example, in cardiac imaging or in perfusion imaging in oncology, we want to measure in real time, ideally, how our contrast agent that we inject is taken up in the tissue of interest, then we simply cannot spend 10 minutes or so or whatever to encode a single volume. It just has to be at a certain temporal resolution. And of course, very, very straightforward way to accelerate any type of MR acquisition is simply to acquire less data. And again, you all know this. So if we just skip every second line in K-space, we have, for the most part, I mean, of course, it depends on the sequence, accelerated our acquisition time by a factor of 2 in the trivial case, but we end up with aliasing artifacts that corrupt our images. So in a way that is not particularly useful on its own, but if we combine it with advanced image reconstruction strategies like parallel imaging, compressed sensing, then we are in general, we have the ability to get rid of these aliasing artifacts and reconstruct high quality images even from undersampled data. So this is just a basic premise that I'm gonna base all my talk on. And what we thought back in 2015 was that, well, if we have at our disposal images where we have pairs of some kind of fully sampled ground truth, and we know how we are going to acquire, or specifically how we are going to acquire an undersampled version of this particular image. We can simply do this in simulation by throwing away K-space lines. If we have these pairs of images available, then is there a way that we can somehow learn which of the parts of this accelerated image are the real image content and what is the aliasing, the corruption that comes from the accelerated acquisition, and somehow train a machine learning model that allows us to separate between those two. So that was the main idea that everything of this was based on, and how we started our developments. And if you formalize this, the concept is actually very, very simple. Right? So you start out with your undersampled Fourier data, which corresponds to your zero filling, aliased, low resolution reconstruction. If you have calibration information about the scanner, for example, the coil sensitivity is available, then you can add them here as well, but you don't necessarily have to. It depends on the particular model that you're using. And then you put this data in some kind of reconstruction model. And let's assume just for this moment that this is a neural network. This model has some parameters, and you will get some reconstruction. And in the beginning, it may look terrible, or at least not optimal, because you haven't trained the network yet. But if you then have this reference available and you just compare the output of your reconstruction to this reference with some kind of similarity measure, and that could just be as simple as the pixel-wise difference of the ground truth reference and your current reconstruction, then you get some kind of error map or reconstruction error, and you can adjust the parameters of your network so that this reconstruction error is minimized. And then you can formulate this as an optimization problem where you simply loop over all the examples in your training data set. And while you do this, update the parameters of your model. And this you can do with any type of algorithm like backpropagation that is used in neural networks, in deep neural network training, to train your model so that your reconstruction becomes closest to the ground truth reference. So this is the core idea, very, very simple. And the one thing that was really interesting to see was how this entire field has evolved over the last couple of years. So I like to show this slide because this was eisengren 2016. And when we first presented this, there were 3 presentations in the entire meeting who had a topic of machine learning for image reconstruction or imaging. One was from Shenzhen in China, one from a Korean group, and ours. And if you look very, very closely, our presentation actually was at 8 o'clock on Friday after the closing party of eisengren. So you can probably imagine how many people attended that session. It was a very sparse session, so to say. But then the next year, suddenly this happened. Suddenly there were tons of presentations on this topic. I think eisengren needed to do 2 or 3 entire sessions dedicated to this particular topic. And I think the year after that, it became its own review category. eisengren didn't have just 1, but 2 workshops on machine learning in 2018. Conferences like MICAI started doing specific workshops for machine learning for image reconstruction. And this is going on ever since. And literally every day, new papers come out with some new method development, some new model. So this is really exciting to see for me, to see how this entire field has taken off. So the question is, or at least how did we approach it? What type of reconstruction model can you use to perform this task? Before I just had this black box block that I said is just a neural network with some kind of parameters. And in our particular case, we were heavily inspired by compressed sensing. And so what you do in compressed sensing is simply you have some kind of optimization problem where you are, you have some kind of term here that maps between the image and the case-based data. So this is just your regular iterative sense reconstruction if you would iteratively solve this type of optimization. And then you have some term that is providing a sparse representation, or essentially some mapping into some domain, and this could be the wavelet domain, it could be total variation, where the image you're trying to reconstruct has a sparse representation, meaning a representation with a number of non-zero coefficients that is smaller than the number of pixels you're trying to reconstruct. And you can also see this if you come more from the inverse problem side as a regularizer. So you are just adding an additional constraint on the solution of this matrix inversion that you're trying to get. And out of all the possible solutions that you can get, you're selecting the one that minimizes both this data consistency term and also this regularizer term. So if you have images that look like these cartoon images here, and let's say your corruption is Gaussian noise, then you can get away with using very, very simple image models. So for example, a model like the total variation and has been used like hundreds of times in the context of MR reconstruction. It works really, really well. You're just penalizing the gradient or the L1 norm of the gradient of your image. And this is a perfect image model for something like these cartoon images that you see here. They're perfectly represented by a sparse gradient. But in reality, when we do MR imaging, 2 things happen. First of all, our images become more complex. They can no longer be really well described with these simple models. And also, when we do accelerated imaging or undersampling, then we actually do have a very, very good understanding of the corruption that is introduced. It's not just random Gaussian noise. We can forward simulate how the images are going to be corrupted and then try to learn how to undo this. And this was the generalization with machine learning that we attempted starting from compressed sensing. So if you just take a look at this equation here, and this was the generalized form with machine learning that we came up with. Again, trying to find the separation of a fully sampled ground truth and the zero filling undersampled version of this image. And it just consists of some spatial convolution filter kernels and some nonlinearities. And we follow the same structure as compressed sensing in the sense that we have this data consistency term. And I always see this as a way to incorporate everything that is known for this particular acquisition of the MR physics side. So what type of trajectory do you have? What coil sensitivities do you have? What is the undersampling pattern? Because this directly designs the type of artifacts or the corruption that you are getting, that you are then learning to undo. And then you are having the part where you actually do the machine learning, and that you then really, really focus on learning to correct for exactly these type of artifacts that you introduce with this type of acquisition. So this is a very, I would say, constrained type of machine learning problem that you really try to nail it down to exactly what type of problem you're trying to solve. The downside, let's start with the upside. The upside of this is that you actually get away with using machine learning models where the number of model parameters is comparably low. Let's say maybe 100,000 parameters or something, which in comparison to, let's say, some huge deep learning model that has tens of or maybe hundreds of millions of parameters. And the reason why I always find that this is important is that in medical imaging or in MR, we usually don't have the amount of training data that the computer vision community has when they are, I don't know, classifying images of cats and dogs that people upload on the internet, or people who do self-driving cars who can do simulations and get tons of simulated data. Usually we don't have this luxury. So using smaller models with smaller data sets is always the area where I felt I'm operating. But I want to point out that this then requires that my known physics model that I assume is accurate. So if I have any errors or deviations from how I model this to how this looks really in reality, then I will have a model mismatch and my machine learning model will no longer be optimal. And I don't need to show you this because obviously this came from your lab, and you have taken this to the other extreme, saying treat everything like a complete data science problem, learn everything, don't assume any of the physics. And then there are many, many models who are somewhere in between these two. And I don't think that there is a right or wrong type of approach here in terms of what model should you use. I think it will always depend on what particular application you want to use. If you have a very, very good understanding of the type of errors and models or artifacts that you're going to introduce, then I think it always makes sense that you try to introduce this knowledge. If you just don't know it, then treat it as an unknown and use machine learning to solve it. At least that's my philosophy, but we can discuss more about it. So in our particular case, then if you then map this type of optimization problem on a neural network so that you can actually solve it, what you need to do is you need to calculate the gradient of this objective function and then do a series of gradient descent steps that minimize the problem that will allow you to get your image. And in the formulation that I have shown you a couple of slides past, you can find an analytical derivative. So this is actually fairly straightforward. It's depicted here, and this gives you your iterative update sequence. So every gradient descent step performs exactly this type of operation. And when you have a structure like this, then you can directly map this onto a neural network architecture. So every single layer of this neural network then has to have exactly this particular structure in order to perform such a gradient descent step. And the reason why I always liked this type of approach is that you have this connection of the neural network data science part to numerical optimization methods, where you have this connection to the gradient. so to speak. So you take away some of the heuristics of the model architecture building, because essentially the model designs itself. So if it is supposed to do a gradient descent step, this is exactly what the model architecture has to be. Of course, is this optimal? Probably not, but then you need to ask the question, what is optimal? So you can, once you have trained this, put new raw data through this model, and then you can actually visualize what is happening at the individual gradient descent stages as the data is passed through the network. And that I always found quite insightful. So first of all, the one thing that you notice is that you are no longer seeing this behavior of a classic optimization algorithm that shows some kind of monotonic behavior where it gradually improves the images and then converges to the solution. Actually, the algorithm here really oscillates back and forth between strongly weighting data fidelity, strongly weighting the regularizer, introducing some very, very weird artifacts along the way. And you could get around this by adding additional training constraints that also make sure that the deviation to the ground truth is getting not too big in every single layer of the network. But we have tried this and found that for the end result, it doesn't make so much of a big difference. So we are usually using the approach where we give the network complete freedom to design its internal structure and adjust its internal weight, and just as long as the output is as close to the ground truth as possible. One comment about this architecture that I would want to make, where I mostly have these discussions with the data science people where they say, don't care about the physics at all, just do an inverse Fourier transform and then treat everything as an image processing problem. And we have done this experiment just to, I think, put a little bit of insight into how much you actually gain by introducing the physics in the model. So what you see here is a ground truth reference and a zero filling inverse Fourier transform reconstruction with a certain undersampling pattern. And what you see here is structure similarity, just in case you're wondering. This number here in the bottom right of the image. So if you are taking everything as a purely image processing problem, so essentially you are training a neural network that tries to map this image to this image here, then you are getting a result like this. And obviously this is an improvement, and the image looks sharper, some of the aliasing artifacts are removed. But if you use the exact same model architecture and introduce the term that maps back to K-space and enforce the consistency with K-space, then this is the result that you get. So I think there is a lot to be gained to really inform the model of where does the real measurement data come from, in what domain is the data measured, and in what way is it corrupted during the acquisition. One caveat with this experiment that I just want to point out for the sake of fairness is that this is the exact same model architecture. Just in one hand, I used the data consistency to K-space, and in the other hand, it was just purely an image space. You can make the argument that if you are treating everything as image processing, then probably you will have a lot more data available. So you probably get away with training a much larger network. So this, just to make sure that this is in the proper context, but for a same sized network with the same training data. And I don't think this is surprising that you just gain by integrating additional knowledge. So these are some of our first results. This was from our first paper where we compared the machine learning model to parallel imaging and combined imaging, parallel imaging, compressed sensing. And we were quite happy with those. because we saw a very reasonable removal of aliasing artifacts. So these are these red lines here. And at the same time, the image texture, the fine details were preserved fairly well. And just show you, just assume, this is one of the oldest first results that was from the 2016 eisengren presentation, where we actually had an image in our data set with some pathology. So this very subtle defect of the cartilage, which is the couple of pixels wide, and we found that it was preserved pretty well in the machine learning reconstruction, and the noise amplification and aliasing artifacts were much better than with parallel imaging converse sensing that we had at that time. So this is just a result from another group. This is an example from Stanford, from Joseph Cheng back at the time when he was there, where they used similar model architecture for abdominal imaging, where they also compared accelerated images with converse sensing and with the machine learning approach, and found essentially the same thing, that they get comparable acceleration rates, SNR, but much better depictability of fine image details. One thing that I've been doing a lot in these past years at NYU is integrating all of this into our clinical workflow here in the hospital, so that we can really do it with patients and really evaluate how well it works in a clinical setting, with all the craziness and the unexpected things that can happen when you scan real patients. And essentially, we use this tool that Tobias Block from our group has developed, which is called Yara, where you just install a software on the scanner. The scanner then sends the raw data away to some kind of reconstruction server. And we have two versions now. We have one that is a standalone server that is in our data center. We also have a version now that runs on AWS in the cloud. And then you get the images back, we send them to PACS, and they go to the clinical radiologists to do clinical studies. And this is the one clinical study that I am running for this for this knee protocol imaging, where we are measuring both our standard clinical protocol, which is roughly a 12-minute total acquisition, and an accelerated 5-minute knee protocol, where we do our machine learning variation and network reconstruction. And we're doing this for the past 2 years. So far, we are at 251 patients that we have enrolled. And so far, the results look pretty promising. So this is an example here of a meniscal tear. And on the top, the clinical reconstruction, on the bottom, the machine learning accelerated acquisition and reconstruction. And in terms of the image quality and the depiction of the pathology, so far it looks like the results are pretty much interchangeable statistically. It's just another case with an ACL tear, again, very similar type of behavior. We do have a version of this that is directly integrated in the scanner and then running on the scanner host. We have it at NYU. We have it with Siemens has it, and we would like it to be distributed as a WIP package so that other sites can use it if we don't have the capability to set up a custom reconstruction scanner, or don't want to send images to the cloud, that everything is staying on the scanner on the reconstruction computer. This is work in progress. Yeah, we are working with Siemens on it. So hopefully it's going to be available soon. One thing that if you have this pipeline in place where you can do clinical scans fairly easily, then it enables you to do different applications fairly easily. So you just retrain the model with a new set of data. So this, for example, is from oncologic imaging, prostate imaging, where we are proposing to do rapid prostate screening in, so this is a 3.2 minute protocol, abbreviated T2 weighting and diffusion. And what you see here is a comparison of the old multiple averages, actually reference scan and an accelerated scan with parallel imaging for reference and the variational network reconstruction. So this is for T2 weighted imaging. This is for diffusion imaging. So we do diffusion weighted imaging in axial and the coronal plane, diffusion imaging in the axial plane, and then with two p-values, p50 and p1000. And so far, we are seeing fairly consistent improvements with the variational network reconstruction over parallel imaging, and also not really significant differences to the longer standard clinical acquisition. One nice thing that you can do with this approach, where you have a forward operator in your model that describes the imaging physics, is that you can actually simply replace this forward operator with a new physics model and then use everything in the same way you did it before. So this is an example for low-dose CT imaging. So there we have replaced the Fourier parallel imaging MR operator with a 3D cone beam projection operator that's used for CT. And then we can essentially use the exact same framework. So what you see on the top here is a full dose scan, and on the bottom a quarter dose scan that was obtained by blocking out projections. This was a separate project that we had together with Siemens, where we built a collimator at the CT source to block out CT projections. And again, you can see very, very similar image quality between the quarter dose scan and the full dose scan. This is another application for oncology, dynamic imaging. And the only reason why I'm showing this result is that I think it really pays off to consider what type of model you use in terms of the data that you're actually acquiring. So this is a dynamic acquisition. And if you train a model that is just doing a 2D slice by slice reconstruction, then yes, you are getting some improvement over just the conventional zero filling reconstruction. But when you treat it as a 2D plus time problem and use convolution layers that have 2D plus time elements, so essentially it's a 3D convolution model there, then you're really making use of the redundancies of this type of data. And I don't think this is surprising anybody. We all know from computer sensing that there's actually a lot more redundancy in the temporal domain if the number of pixels that change over time is small in comparison to the entire image. And just to reiterate that, of course, the same concepts still hold when you do a machine learning reconstruction. Where it's getting a little bit tricky though is if you are training this model again on an image by image basis to some kind of ground truth, and in this particular case, we don't even have a ground truth. So we train everything with numerical simulations and then apply it to real data. But you end up with this problem if you take a look at the signal time curves in the lesions, that even though you get an image that looks far substantially improved to, let's say, the zero filling reconstruction, the model has a tendency to smooth out sharp signal changes. And that is a real issue, because that is really the diagnostic information that we are trying to measure here. So you may not even be interested in seeing a really, really nice looking image, but the quantitative information is what you care. And if you don't tell the model that this is the important information, if you just train it with an image-based error map, the way I've shown it in this optimization problem a couple of slides earlier, then the model is oblivious to that. And it will give you the result that optimizes mean squared error or structural similarity, but it doesn't care about the contrast dynamics. So one thing we are doing in this context is we are actually calculating kinetic parameter models. For example, standard compartment modeling. There's a lot of work out there in the perfusion community, and then evaluate the results that we are getting based on these kinetic parameters. And then in the next step, what we are currently working to do is actually directly integrate these models in the machine learning acquisition and reconstruction, so that we have a loss function that also penalizes the error on these quantitative maps. So then the model is really, really learning to give you the optimal result with or at the level of these quantitative parameters. The other project that we are working on in this context of breast imaging is actually doing classification. So we have a very, very big group that does image-based diagnostic classification for breast cancer. And we are getting fairly competitive results classifying malignant or benign breast lesion on MR. And then what we are working on doing is, again, combining the classification that is used or done doing a neural network with the reconstruction that is also done doing a neural network. And since they are all differentiable models, there's really nothing that can hold you back from putting the whole thing together and optimize it as one joint optimization problem. One thing that I want to just briefly mention that we are working on is low field imaging. And you can ask the question of, when you have all this compute power available, can you actually use it to relax some of the constraints on the hardware? So we have this prototype clinical scanner, which is a 1.5T scanner that's ramped down to 0.55T. It's the same type of scanner that's at the NIH, in case you have seen this particular system. And we were investigating, can we do, or what type of fast, low resource neuroscanning protocol can we do? And we just played around with this a little bit. And these were the type of images that we were able to get. I mean, since you are mostly in neuro side, I thought these are mostly for interest for you. This is just a T2 weighted acquisition. I think resolution and SNR is comparable to what I would expect clinically. Problem is that in order to get this, we need to do 6 averages. So we end up with a total scan time of about 15 minutes just for this one single sequence, which is obviously too much for clinical translation. So we wanted to get this down to below a minute, and it ended up being a single average and 3 times acceleration. And when we use our machine learning reconstruction with this type of acquisition, then this is the image quality we get. It's a little bit blurry, as you can see. It doesn't have the amount of detail that you would expect, of course, in a 3D clinical scan, but it is a low field system and it's a 1 minute acquisition. So I would say you have to be fair to what you compare this result to. One application where I think this is really interesting is implant imaging. So this is the result of an experiment that we did where we put a hip implant phantom in the low field system, and we compared a dedicated metal reduction sequence, it's called CMAC, between the 0.5T system and the 1.5T system. And what you can see is actually that you get a pretty substantial improvement in terms of the reduction of the susceptibility artifacts that are much lower at lower field. So if you just take a look at this spherical head of the implant, how much more distortions and signal void this has on 1.5T, obviously at the cost of reduced SNR and also longer acquisition times. So what we are hoping to do is to use machine learning to get back some of this SNR deficit and reduce the acquisition time, and then leverage the effect of having fewer distortions, but at the same time, reasonable scan time clinically reasonable scan times and SNR. So one thing that I want to point out here, and switching gears a little bit, is now I've shown you all these things where I think things work very, very well. And I want to point out a couple of issues that I observed. And the first that I really, really noticed was in the first couple of years when this entire field took off, the papers read mostly something like this, right? So we tested our algorithms on 10 patients. This was actually our paper. So I'm not pointing fingers at others, I'm including us as well. Then there is a healthy volunteer. This was from your lab. 27 patients, 7 subjects, 3 subjects, 10 subjects. You get the idea. And it is really, really hard or what I noticed reading these papers, and I think this is true for the entire research community, to compare method A with method B if method A uses a different training and testing data set that is then proprietary or not shared than method B. And then if method B outperforms method A, then I really don't know where this performance improvement comes from. Is it from the technical advancement that is described in the paper? Or is it because the data is higher quality? Or is it simply an easier problem? It's just very, very vague. And so to address this, I spent a lot of time at NYU convincing people to archive data, put data together, and then make this data actually publicly available. So this is this database that we have been building for the last couple of years. We started making all the data from our NEEP project publicly available, meaning the raw case-based data, about 1,400 cases, and then about a year later added just over 7,000 neuro brain scans. And if you're interested in this data set, you can just look at this webpage here. You can, on the bottom left, you can download it and use it. No need to write a research proposal or anything. And then we also organized the reconstruction challenge. And the way we structured this was we gave people the training data set and then provided them for a limited amount of time undersampled data where we held the ground truth back. They sent us the reconstruction. We evaluated them first by comparing them to the ground truth reference. We made a leaderboard and then actually sent the top entries to clinical radiologists for evaluation. And we had some really, really interesting results, and that I think are fairly representative of the models that are out there in the community. So this is an example from the 2019 challenge. These were the top 4 contestants. And this is 8 times accelerated. So this is much more aggressive than what I'm using in my clinical study. So we really wanted to push these models in this particular challenge track. And the one thing that I think is completely striking is if you take a look at these results and compare them to what you see on the far right. This is a parallel imaging compressed sensing comparison that I did after the challenge was concluded. And I knew the ground truth. I looked at the ground truth. I used my own method, this total generalized variation that I know in and out. And I tuned every hyperparameter in there, well, it's only one. But I really tuned it very, very carefully to match the ground truth as closely as possible. So I did an inverse crime, I looked at the result, but obviously all this information the participants didn't have. And just take a look at the amount of improvement, like how they outperform my reconstruction. I think that is really, really telling. The one issue that we discovered was in some of these, because this is a clinical data set, there is pathology. So this is a meniscal tear, and you can see that it's not visible particularly well anymore in any of these reconstructions. So that doesn't mean that the reconstructions specifically filter out pathology which is something that many people in the community seem to have feared in the beginning. It's simply that this was accelerated too much, and this information is simply not in this reduced k-space anymore. And you can see this if you look at the parallel imaging reference. This is a completely useless image, and you cannot see the meniscal tear either. Where it's getting a little bit tricky is if you present a radiologist the image on the far right, they will never make a diagnosis based on this. They will simply say, yeah, bring the patient back. This is unacceptable, something went wrong. Whereas some of the machine learning reconstructions actually look fairly decent. And then it's a little bit tricky to spot or give people an idea of how much trust can they put in these images, because these images may look better than what their actual information content is. And we observed this also in the next year. So this is a result just for the generalization of models to different scanner vendors. So here you can see that most models actually did a fairly, fairly good job when they were trained on data from one vendor and then applied to data from another vendor. Some models struggled, and sometimes the differences between this data were really, really subtle. So in this case, the reason why the model on the far right fails is simply because GE doesn't include readout oversampling in their raw data. So they averaged those together, and this was the systematic deviation that caused this model to fail. So sometimes the devil is really in the detail. We also found hallucinations that, again, can look a little bit like imaging features. So for example, this was a reconstruction that looked well, but this artifact looks almost like a blood vessel. We had areas where just features were introduced that could look like anatomy. If you don't know it, and we have shown this to clinical radiologists, they can tell that this is an imaging artifact. And that then becomes tricky. And we tested this, and you can test this very, very easily in a systematic way by just progressively increasing the acceleration. And usually these things happen when you get greedy. You are accelerating beyond what's possible, and then the model needs to make up features. So for example, this is a 256 phase encoding line acquisition. And what you see here is a reconstruction with 128 phase encoding lines. On the top, machine learning, on the bottom, just zero filling. And you see that it does a really, really good job, great image quality, up to almost an acceleration factor of 10, 21 phase encoding lines. But then what's really interesting is what happens if you go below that. So if you do another acceleration, going down to only 11 k-space lines, this is what you get with zero filling. So obviously you don't even get anything anymore that resembles a brain image. With the machine learning reconstruction, this is what you get. And this is, I think, a remarkable image. I mean, consider how little data you have available, that the model is still able to get this information out of the data. But the problem is you have this really, really huge abnormality in there, and this abnormality is now gone. So these are just images where we have to be a little bit careful and know when they fail. And you can go more crazy with this, go down all the way to 3 k-space lines. And the image on the far right here, again, the fact that the model is even able to tell you that this is a T1 weighted brain image out of what is just a blob of gray signal values, I find pretty remarkable. And I would also say that if you consider the context of an image like this from such a small amount of data, you can still say this is a brain image and something is wrong on the bottom right of this image. And for some situations, this may be all you need. If you think about low resource frontline scanning, just don't expect that this is a clinical image from a 3D scanner in terms of how much trust you put into it. And this is just another example that shows you that this is independent of the contrast. So the model can also learn to reconstruct T2 weighted images, simply the same behavior. One thing that we are working on here is estimating the uncertainty of our models, and we are developing stochastic models that allow you to get an ensemble of images, and then we can get a mean and a standard deviation. And essentially, together with your reconstruction, you are getting a map that almost acts like a confidence map, where you can now see which areas the model was very certain and did not have to make up for a lot of information, and in which areas the uncertainty was higher. So I'm thinking maybe this is something where if you present this to a clinician and then they see something suspicious and they're not so sure about it, and then they see, oh, this is actually an area where the amount of trust that you can put on the image is not so high, then maybe hesitate putting a diagnosis on this. But this is still ongoing work. Another thing that I just wanted to mention, just as the last thing, is that there is this technology of adversarial attacks. There was a paper that came out last year, I think that got quite a little bit of attention, where you actually specifically perturb your input to a trained model to see or try to make it fail as much as possible. And I think that's a really interesting or powerful technology to have at hand, because you can really test your models and see in what way will they fail and what will the results be. Okay, this was all that I wanted to show with you, a little bit of a history of machine learning for image reconstruction, for the MR acquisition pipeline. Talked a little bit about this idea of integrating physical information or physics information into machine learning, and talked a little bit about the pitfalls, both in terms of removing features or hallucinating new ones. And we need to do, I think, as a community, understanding or increasing understanding of these models in terms of the behavior, both on the clinical side and also on the basic science side, to understand everything better. All right. Thanks a lot.
Thank you very much, Dr. Knoll, for this great talk. And we now move to the Q&A phase. So I'd just like to remind everyone again to please address any question you have, either using the Q&A box or just raise your hand. And while people are typing, I'll just quickly ask for the 0.5 T scans. You showed some remarkable improvement where with the machine learning. I just like to make sure, I'm not sure I followed. Did you use the image with a lot of averages and repetition as your training?
Yes.
Okay, got it. And
it
could you...
was the same model with the supervised approach, where we used the 6 average fully sampled image as the training target and the accelerated single average as the input. Yeah.
Right. And do you think that could be useful to also train using, I don't know, scanning the same subject at 1.5 or 3T? Is that something that did you consider doing?
This is tricky, because you really then need to have them exactly matched in terms of the resolution. They need to be exactly co-registered. Even if you have a 1 pixel shift between the two, then this will completely dominate the error in your training metric. And then probably what you will end up is training a model that learns to undo a linear shift, and not really the problem that you want to solve. So I would say, if I would do it like this, I would probably start with the 3D scan, add noise to it, and have a noisy version and train it like this.
I see. Great, thank you. And the next question from Zhou Wen. Can you please unmute?
Yeah, thank you. So my question is that, is it possible to use adversarial learning like the Gans to estimate the uncertainties in the reconstruction? So I think the Gans, we don't always have the closed form posterior for how to say, the formula of the Gans. So is that possible to estimate the uncertainty in the reconstruction? Yeah, that's my question.
Yes, I mean, there are lots of approaches with GANs, right? I mean, this has been studied quite a bit. I think what makes GAN results even more tricky is that the amount of hallucinating features, or the possibility for that, is even higher, because they are really trying to get you an image that is visually pleasing and visually closest to what is in the training data set. The problem is it will always give you some kind of interpolation of the training data set. So I think there is some work out regarding Gans. We did a little bit as well. We switched over to Gaussian mixture models just because they are a little bit more benign in terms of understanding their properties. But yeah, I'm not a Gan expert anymore, I have to say.
Yeah, appreciate it. Thanks.
Right, next question from a video. Can you please unmute?
Yeah, yeah. Hi, hello. Very great talk. Yeah, I was wondering about the metric that's used to judge the quality of image reconstruction. Like you mentioned, SSIM at the beginning and there are many papers that discuss what's the best metric to judge feature FSIM, or you mentioned something at the end, stochastic. The stochastic metric, is this includes, is it based on SSIM? So you calculate a lot of images and you calculate the SSIM for each of them, and then you the stochastic metric is the average of those results, or how is the, I didn't fully understand, or, and if you can comment of, yeah, what other alternatives are for this metric beyond what you mentioned or what I asked, if you have other, any good advice.
So I think these are two answers because these are two separate, slightly different questions. So yeah, sorry, I only rushed through the uncertainty estimation, the Bayesian models. So what we are doing there actually is, this is not really the loss metric. What you see there is that we are not training a deterministic set of model parameters, but we learn a distribution of actually the parameters of the model. So every single network parameter we now treat as a distribution of parameters, and then we sample from this distribution. So then the maps you saw at the end is then simply that the output of the machine learning model is a set of images, let's say 32 images, and from that we calculate the mean and the standard deviation. But that is actually not really part of the error metric. That is then just how you can visualize the end results. And I see this more as some additional information after the model is trained, that you have information about the uncertainty of the model itself. In terms of the training, I think every single time you have the ability to go as close to the quantity that you are really, really interested in a certain application, that you if you can integrate this in your error metric for the training, you should. So the problem that all criteria like mean squared error, structural similarity, whatever it is, have is that they are global measures. So they are just giving you a single number for this entire image or even for an image volume. And if small features are removed, it's not really showing up there. So if you have any, it depends on the problem, right? So if you are doing fMRI, you might look at the activations. If you're looking at perfusion, you might look at perfusion maps. So I will always try, and if you have, especially if you have a quantitative metric, then I think you're in a very, very strong position, because then you can really quantify the results of your error. If it's clinical qualitative imaging and you always rely on radiologists looking at your images, telling you, this is great, this is lost, then of course this is necessary, but you can never iterate over something like this in a machine learning training area. So it depends on the application, I would say, and if you can quantify it, then you're in a good position.
Thank you for the clarification.
Next question from Alexander Lin. Alexander, can you please unmute?
Oh, hi. Yeah, sorry, I typed my thing in the box, but I can rephrase. So I was wondering, can you comment a bit on kind of if radiologists find this Bayesian uncertainty map that you talked about useful? Because I could definitely see how it's very useful and like it gives you a sense of where reconstruction error may be, but it does seem like it would be more work for them and it would require like more time for diagnosis. So what is their like general reaction on this?
Yeah, I think there you clearly have to differentiate demographics of radiologists. So at NYU, at an academic, and it's going to be the same for you at MGH, I guess, where you have academic radiologists who always want to be at the cutting edge of technology, and they see this and they love it. But if you go to some kind of, just standard patient care hospital, and this is not meant in a grading way that one is better than the other, but if your standard practicing radiologist who just scores the images, I don't think that they would actually want to see this, because they are operating under the assumption that they can trust the images. So if I suddenly tell them, maybe you cannot trust the image here, I don't think they would like this at all. So I think it is something that is useful for an academic setting, but not so much for clinical practice.
Got it. Thank you.
Next question from Bruce Fischel.
Thanks for the great talk. It was super interesting. So you used variational in the name of a bunch of your networks. Should we understand that you had variational layers and that was important to getting the results that you obtained?
The variational name comes from this architecture or this approach where every single network layer does a gradient descent step. And that allows you to connect the model optimization to variational optimization. So if you are deviating from this, for example, if you're using an architecture where you no longer have a differentiable model and you can no longer describe what is happening in the optimization in terms of a gradient, then you are deviating from this. But so this is just a name that we use to connect this to standard iterative reconstruction variational optimization.
I see. So it's not like a variational autoencoder where you're learning means and variances in a latent space.
No.
I see. Okay, thanks.
Okay, so I think that concludes our Q&A session. Thank you so much again, Dr. Knoll, for coming here today, and we hope to see you next time in person.
I hope so too. Yeah, thanks very much for the invitation. It was a lot of fun. Bye.
Bye, everyone.